just presented a case of a patient who was diagnosed many years ago and is still fortunately doing well. Fortunately for us, things have changed. Standards of care have changed, and we have developed new therapies, and how we think about treatments have evolved. And we can start really with the front line. So patients who are diagnosed now with advanced ovarian cancer, one of the first things we want to know is whether or not that patient has either a mutation in her BRCA gene that she was born with, which is called a germline mutation, and we also want to know, or want to know, whether or not she has a mutation in her tumor in that BRCA mutation. So in a patient who does not have a germline mutation, when we think about high-grade serous ovarian cancer, which is the most common type, about 18% of patients are going to have a germline BRCA mutation, what we would refer to as a BRCA-associated cancer. But if that testing is negative and you test the tumor, you'll find about another 7% of patients who have a mutation, what's called a somatic mutation in their tumor. And so it's incredibly important that we identify those patients really as early as possible, certainly once we have the diagnosis confirmed and the patient has recovered from surgery. If that was the chosen path, we really want to get this testing sent because it does impact how the patient is treated in the front line. It doesn't impact the choice of chemotherapy. That has remained the same, with doublet chemotherapy, carboplatin, and paclitaxel still being the standard of care with or without bevacizumab. And that is a new finding as well. It's a new indication for patients with advanced disease. They can have bevacizumab added to the front line, and then after a response, continued for about 15 cycles. So that's one option. But for patients with a BRCA-associated tumor or a mutation in the tumor, somatic disease, the new standard of care is chemotherapy with a response, which is very common. About 80% of patients have a response, followed by the PARP inhibitor Olaparib maintenance therapy until progression or until the 2-year mark has been met. And at 2 years, if the patient is still ongoing on Olaparib without progression, the treatment is discontinued and surveillance, close monitoring ensues from there. So there's 2 changes there I just talked about. The Olaparib indication is a result of the study called SOLO-1, which was presented in 2018 and has led really very rapidly to global approvals. They're still ongoing because of really unprecedented improvement in progression-free survival in this particular population of women who have a BRCA-associated cancer. The progression-free survival for the group that received placebo is right around 13.8 months. And for those patients that received Olaparib, again, just for 2 years, the median progression-free survival in the study wasn't yet reached, but it's estimated to be around 49 months. So the hazard ratio there was 0.3, so 70% reduction in the risk of progression. So again, unprecedented results, the order of magnitude of which we have never seen in ovarian cancer, and so it is the standard of care in that population. Bevacizumab was also approved since our patient in our last case in the front line. And so that is based on what's called Gynecologic Oncology Group 218 in the US, and ICON 7, which was a European study, not quite exactly the same, but very similar, where they enrolled patients, gave them bevacizumab with chemotherapy and to follow as compared to placebo and placebo maintenance, and demonstrated a statistically significant improvement in progression-free survival with an improvement in the hazard ratio for progression as well. Not as robust as what was seen in a biomarker-directed study as SOLO-1, but still an improvement in progression-free survival. And so the decision now when you have a new patient with ovarian cancer is, what do you do? What do you start with? Do you start with a bevacizumab-based regimen with the chance that you're going to discontinue the bevacizumab if the patient has a BRCA-associated cancer because you're going to put her on Olaparib to follow? Or do you wait for the genetic and genomic testing and then make that decision? And there's not an easy answer to that question, but those are the treatment decisions that we're having to grapple with right now in the front line.